Jason, look, immunotherapy has a profound effect but on several patients, but who are not actually responding well to immunotherapy?
Well, so we see with the approval of these drugs, there are certain tumor types like melanoma and lung cancer that disproportionately benefit, but we know even within those tumor types, some patients are not benefiting. And it's quite clear at this point that those tend to be patients whose tumors have low expression of PD-L1, or if we profile by next generation sequencing, have low expression of genes centered on interferon gamma, or low levels of mutations in their tumors. So these are all already actionable biomarkers that we can include when we think about how we are going to treat individual people.
So the standard of care today is PD-1 and CTLA-4. What do you think the standard of care will be in the next 2 to 5 years?
So immunotherapy has come forward with the checkpoint molecules you discussed, and I think currently we're in an era where we're seeing those combinations with chemotherapy or other standard of care therapies emerging forward. So I think moving 3 to 5 years from now, what we'll need to see is who can get immunotherapy only, or who needs immunotherapy with standard therapy like chemotherapy or radiation and these kinds of treatments. So I really think that will be the next generation question, is how do we separate those two things?
So the movement away from monotherapy to more diverse therapy?
Yeah, combinations of treatments.
So you have said that the future treatment landscape of cancer will be more or less like how to manage chronic diseases. Can you elaborate a little bit on that one?
Well, I don't want to say we're beholden to that, but rather that we can induce these immune responses, which are sometimes incomplete, but we can move that forward to improve the outcomes for patients over long periods of time. So clearly our emphasis is to eventually get to a place where we completely cure the patient. However, over the near term, really maximizing the use of the drugs that we have to improve the survival of individual patients is what we're going to focus on.
So can you tell us a little bit about the next generation of immunotherapy or precision medicine? Because you are a researcher in phase 1 primarily, so you are now looking into the drugs that we will have the next 5 to 10 years.
Right.
So can you tell us a little bit about the landscape you see?
Yeah, so the landscape is exploding with possibilities, and really what I think the emphasis needs to be is to incorporate the knowledge we already have to better understand what can be done. So when we think about separating patients' tumors by whether or not there's an immune infiltrate already, or whether or not we need to stimulate such an immune infiltrate, that can actually tell us which categories of new drugs we might want to apply for different people. So say there's already an immune system, then adding another checkpoint like LAG3 or TIM3 might be a priority. If there isn't already an immune response, maybe stimulating that immune response through dendritic cells and type 1 interferon activation really might be the priority there, so that we can just start sort of prime the pump so we can give immunotherapy a chance to work.